Good morning from the annual meeting in San Diego. We're pleased to be here with Dr. Liz Yu. Liz, good morning and thanks for being with us.
Good morning. Thank you for having me.
Liz, I think one of the really challenging things for cataract surgeons is approaching these really dense cataracts,
Sure.
these really brunescent cataracts and white cataracts, and sometimes even a blend of both white and brunescent.
Absolutely.
This is a topic that is so important for surgeons to be prepared to do well in these cases. What are some issues and some pointers that you can offer to suggest for success?
Sure. In my own experience, oftentimes the challenges that we have with kind of approaching that white intumescent lens is oftentimes different from that very brunescent lens. So let's start with the intumescent ones. There's a lot of positive pressure, that white fluff. So the Argentinian flag sign, that very fearful poor capsulotomy or capsulorhexis creation is really going to be one of the biggest hurdles to start with. Obvious visualization is going to be key with using trypan blue, but either needle decompression, good amount of viscoelastic to make sure you're nice and flat. For my needle decompression, I like to use either a 27 or 30 gauge needle, bevel down, empty syringe. I enter right where I would puncture with my cystotome needle and withdraw slowly. I don't need it to make it so concave that would be challenging to create a rhexis that way, but at least to ensure that I've gotten rid of or mitigated some of the pressures coming up from the actual lens itself. And then oftentimes, if there's not a brownness or a brunescence in the core, the lens itself is actually quite brittle. And it's surprising that the energy is not going to be nearly as high as one would have expected. And in a younger patient, sometimes it's actually quite soft beyond just that, just being a white appearance. For a very brunescent lens, if I see any white to it with the actual endo capsule, then I will definitely do that needle decompression. But the more density I see, so the closer to mahogany or black the lens is, the larger my capsulotomy is going to be in case we need to convert to kind of a mini extra capsular surgery or if phaco can't be performed, which is very rare in this stage. And the actual lens disassembly can be the most challenging part, particularly because the posterior portion of the lens oftentimes is quite leathery. So this is where divide and conquer may not work quite well. For me as a chop surgeon, I feel very comfortable with primary chopping, but I would say that primary chopping of the pieces of the nucleus is a technique that you don't want to start with these dense lenses, but get used to it with your normal lenses. And it's not just going to be your 4 quadrants. It's taking each quadrant and kind of cutting it into smaller and smaller pie pieces. Even other utilized devices, newer technologies like the MyLoop can be helpful here in order to really mechanically disassemble and break down the nucleus more so than using energy to do it, if that makes sense. And it may not look so elegant because you have to kind of really pull through and push those pieces apart. And the Nagahara chopper does a nice job, and that's what I use. Lots of viscoelastic dispersive to protect the endothelium. And then remember, there's very little cortex in these very brunescent lenses. There's a lot of thickness to that lens, so it's going to be floppy with little cortex and a dense piece. So surges are going to happen when you're down to your last piece and you have this great red reflex. I will reposit viscoelastic into the capsule and also use my Coke spatula to kind of hold it back, slow everything down in order to take care of that last piece and not really go all the way down because I don't want to experience the surges.
Liz, that's such a great point that you just brought up about slowing down this procedure.
Yes.
In order to set ourselves up for success, we really want to take our time with every step of the procedure that you so eloquently described. And I find it also useful in this circumstance to announce to your surgical team in the OR, this is going to be a challenging case.
That's
I'm going
right,
to go a bit slower, and maybe some more time so that I'm not in a rush to rush to the next procedure.
Yeah.
And so it definitely helps in that way. I'm wondering if we can close by speaking about femtosecond technology in these specific scenarios, how do you find the femtosecond to be useful or not useful in these scenarios?
Sure. Especially for doing a capsulotomy, I know that with the Catalyst, I have not used it. It makes the quickest capsulotomy, like sub 1 second. It's great for those white intumescent lenses where there is that positive pressure. But if the docking is going to be huge, because if it's not flat and planar, then there's greater chance that you're only getting parts of the capsulotomy first. There's plume that comes out with a white nucleus, which then will occlude the laser from getting to the rest of it. So you're going to get tags, and expect that. Not necessarily an Argentinian flag, but know that when you get to the operating room, you will have tags, so trypan blue is still essential. With that being said, for the lens fragmentation, which is such a nice benefit for dense lenses, but if your lens is so dense that you have no red reflex, just keep that in mind, that the lens frag will probably also be poor. This is both with white cataracts as well as black or mahogany cataracts.
Liz, this has been such a fantastic discussion this morning about really dense cataracts and white cataracts and how to set ourselves up for success in the OR. Thank you so much for sharing your expertise, and thank you to our live audience as well.